So it's nice to have you this afternoon here in an interview. And I would like to start with you, Rob. You come a long, long way from Australia. And the question is, what made you come here to Italy and talk and discuss about a receptor of the renin-angiotensin system, which we call AT2 receptor?
That's a loaded question, but apart from the great company and the beautiful country and food, this was really a great melting pot of ideas where we can talk about the AT2 receptor and just to keep up to date with the latest research, which is very promising and looking at new therapeutic targets for the AT2 receptor.
Well, you say new therapeutic targets. When you started to work on the AT2 receptor, which is quite a couple of years ago, what were your ideas? What did you want to find out about this receptor?
Well, to me, it always seemed to be the receptor subtype that was less well studied. We had the AT1 receptor, and of course, when you block the AT1 receptor, therapeutically, we had AT1 blockers, which are now conventionally in cardiovascular medicine. But at the same time, we know that there is an increase in endogenous amount of angiotensin II that can stimulate the other unblocked AT2 receptor. So of course it was of interest to see whether or not it had particular pharmacological actions in its own right. And so for a long time, myself as well as many other people have been looking at trying to understand the pharmacology and physiology of stimulating directly the AT2 receptor.
Well, you certainly started with a certain idea about this receptor. Maybe you thought it's lowering blood pressure like the AT1 antagonist or whatever, or it's increasing blood pressure like angiotensin working on the AT1. So what was your first surprise with this receptor?
Well, I thought it might be an antihypertensive because when you look in isolated blood vessel studies, you can see relaxation, but that most of the time doesn't translate in vivo to an antihypertensive effect. But what we do see when you chronically treat with compounds that can stimulate the AT2 receptor, you see some remarkable organ protection. And this can be in the heart, for example, or in the kidney, and you get a remodeling of the extracellular matrix, and in particular, you get quite a striking antifibrotic effect with compounds such as C21.
So the original idea that some people entertained that you would develop this compound which stimulates AT2 as an antihypertensive, that is probably not a meaningful one.
Probably not, but I think some of those same signalling mechanisms to do with nitric oxide probably have a role in its remodeling capacity, particularly might play a role in its antifibrotic activity, certainly a role in potentially interfering with some inflammation pathways as well. So I think while you don't have to have a blood pressure lowering effect, it can still have some direct effects in tissues.
Mm-hmm. So it could be an adjunct or helpful in this respect. Well, Colin, you have been impatiently sitting here now and waiting for your part, and of course you are a brain man, I would say a brainer, and most of your time in the past you have spent with brain mechanisms, more or less around the renin-angiotensin system, finding out about angiotensin in different areas of the brain, what it's doing there. So now you also occupy yourself, at least partly, with the AT2 receptor, and especially also with compound 21, which is an agonist of the AT2 receptor. What brought you to think that there is something going on in the brain with this system?
Well, I've actually done a lot with the AT2 receptor for many, many years. I guess back in the early 90s, we did a lot of electrophysiological studies with the AT2 receptor, really honing in on ion channels that could be modulated by it. But the goal of those studies was really, honestly, just to show that the AT2 receptor actually did something, had a physiological effect in neurons. But as far as taking it further to a more cellular action or whole animal action, we didn't do that. Obviously others like yourself did that. How I got to it more recently was because actually I had a major interest in stroke from angiotensin 1-7 and MAS. And over the past 7 years or so, we developed a big interest in that and were studying the beneficial effects of Ang1-7 and MAS. And then with C21 becoming available and looking at your studies, looking at studies from other people, from Rob, for example, I was and looking at the tie-up really between AT2 receptors and MAS and the potential that there could be interactions with those, we decided that it would be nice to look at the effects of C21 in our stroke model.
So the stroke model was important for you. But let's go just one step back. You mentioned that you started with electrophysiology in the brain.
Absolutely.
And the AT2 receptor. So I would be very interested. What came out of these studies?
We showed back in the early 90s that we used to use this model system of culturing neurons from the brain, beginning with just whole brain cultures and then progressing to cultures of hypothalamus, cultures of brainstem. And simply our interest at that time, where the prevailing thought was that angiotensin type 1 receptors were doing everything, we thought that, well, if the AT2 receptors are there, we wanted to understand if they were functional. What did we do? We cultured cells, we did patch clamp experiments with electrophysiology, and we showed that the activation of the AT2 receptor had discrete effects on potassium channels and on specific potassium currents. And then we looked in a later study at the effects of AT2 activation on actual neuronal activity. But at that level, it didn't really translate into a physiological, a whole body physiological effect, purely because really at the time, without something like C21, I think it was pretty difficult to get around the fact that the overriding effect of angiotensin was pressor, was an AT1 effect. And so I think we didn't let it drop. It was always in the back of our minds, but we knew that there were specific effects of AT2 activation, and we knew it was G protein mediated. We published a paper on that. We did some work with intracellular signaling pathways with inhibition of MAP kinases, but as far as taking it to a whole body level, we dropped short of that. We did attempt at one point, I will tell you, to correlate the possibility, some of the activation of potassium channels can be actually correlated with apoptotic events. And so since AT2s in some studies led to apoptosis, activation of AT2s led to apoptosis, we thought there may be a link there.
That's interesting, because when you think about activation of potassium channels, you immediately think about whole body physiology, actions in the heart, action wherever you have potassium channels, and then you think, oh my God, this could be.
But in terms of neuronal physiology, usually activation of potassium channels leads to inhibitory effects. So, and I think at the point now is we're coming back to with what we're doing now with the use of this new AT2 reporter mouse that we have. We're actually being able to identify exactly, we think, where the AT2 receptor containing neurons are and what they impinge on, what they connect to, and we can look at the phenotype of those neurons. So we can now go back to our former knowledge of, well, activation of an AT2 does this to a potassium channel, or potentially something to a calcium channel, and we can almost translate that, what is it going to do to the activity of this neuron? Therefore, is it going to affect a preautonomic neuron? Is it going to affect an AVP neuron, for example?
I think the development of this AT2 reporter mouse, which sounds funny to lay people, a reporter mouse, but it reports obviously on the presence of AT2 receptors wherever you put your probe on. And this is, I think, very, very important and made a great progress to the research, because in the past it was not really clear where in the brain you would find the AT2 receptor. And this relates to brain areas, like the forebrain or the cortex or the cerebellum or whatever we have in the brain. brainstem, but also to cellular components and see whether it's on neuronal components or it's on more glia and whatever. And I think with the antibodies that we had before, with all the problems about their specificity, it was really difficult to localize and pinpoint angiotensin AT2 receptors in the brain. Now with this reporter mouse, it seems to be relatively, not easy, but it seems to be manageable. So what did you find? Where are the AT2 receptors in the brain?
Well, let me that's a very good question. Let me start back with where they were before. And you know the story, and I think you know my impression of the AT2 antibodies that are available. I think the autoradiographic techniques that we used were pretty good, but I think the autoradiography, while it gave us a view of where AT2s were, of where AT1s were, in particular, I think it undersold where AT2s are. There is, in my opinion, a glitch with the autoradiography where it can really underestimate the amount there. So if you look at autoradiography, and I think it really gives you an idea of, okay, it gives you an idea of where it's there in high concentrations, but it doesn't give you an idea of where it's there in very low amounts. So with that in mind, we, as you said, we developed this AT2 reporter mouse. Where is it? We're finding it in a lot more areas than we thought we would. We're finding discrete neurons. I would have to say, in terms of, is it in neurons versus glia? In the normal animal, okay, unstimulated, non-pathological animal, we believe it's mostly in neurons. We have done co-staining with astrocyte markers, we've done co-staining with microglial markers, and at the moment we do not see an overlap. That doesn't mean that it's not somewhere that we haven't looked. However, we know from other studies, studies done by yourself, studies done by Musha, studies from my lab, we haven't published them yet, that if we isolate microglia from the brain, we can measure AT2 receptor messenger RNA. I think Musha has done studies, and you have done studies with astrocytes isolated from the brain, which have AT2 receptors. So what does that mean if we can't see them in the AT2 reporter mouse? Possibly what it means that in the normal animal, that there isn't much expression there, but if you challenge the animal with something like a stroke or some other kind of pathology, it potentially can be enhanced, and that kind of enhancement you would see in a culture situation. As I said, though, we haven't surveyed the whole brain completely to know that it's absolutely not in astros or not in microglia, but if we give it an overall look, it does look to be largely neuronally localized. In terms of types of neurons, I can give you a little bit of information about that because that's all I have. We've looked at the NTS, the nucleus tractus solitarius. We were very surprised it does not co-localize with catecholamines or with tyrosine hydroxylase. We have looked in the DMV, we've looked in a little bit in the NTS. It clearly co-localizes with choline acetyltransferase. It co-localizes with GABA. Some of the neurons which surround the PVN are GABAergic neurons. So there is the possibility, if we can localize exactly where the AT2 receptors are on those neurons, we can then come back and perhaps develop some hypotheses. How would activation of an AT2 receptor affect a GABAergic neuron or a cholinergic neuron?
Well, this is a whole wealth of things that could happen. Just a final question to you in this block. When you think of a drug that should interfere with angiotensin receptors, AT2 receptors in the brain, would you think that this drug has to pass the blood-brain barrier easily? Or could you also think that it's enough if this drug gets into the microvasculature of the brain and also maybe into areas where there is the blood-brain barrier not so tight, like in the subfornical organ or in the brainstem area postrema and so on? So what's your ideas about that?
To me, the ideal would be to have a drug that does pass into the brain, because then you cover all bases. You can get a drug that goes into the brain, affect the brain parenchyma, you'll affect the microvasculature. However, to backtrack a little bit, obviously normally we have a blood-brain barrier. In certain situations that blood-brain barrier is broken, such as in stroke, which is a more dramatic situation. However, I think in certain other instances, such as chronic hypertension, such as obesity, induced hypertension, I believe that the blood-brain barrier starts to get a little bit leaky. So in those situations, it may be possible to get an AT2 receptor ligand in there. But I think the development of a drug, an AT2 agonist, which is blood-brain barrier permeable, to me would be the ideal. And then you can, as I said, cover all bases.
And you wouldn't be afraid of unwarranted effects in the brain, like we have experience with antihypertensives that make you tired or have some other brain-related effects?
That's an aspect, and maybe one thing I should mention, or that goes across my mind frequently, is again we have to know the absolute mechanism of action. Often we're more interested, well, okay, we put in an agent and it has a beneficial effect, and the mechanism, well, okay, that's fine, but I think we have to know the mechanism, because if the mechanism is, for example, in stroke, if it's upstream, if it is something to do with the vasculature, if it's something to do with preventing leukocytes from entering the brain, for example, macrophages, some part of that early stroke process, we need to know that. In that case, we wouldn't need to have a blood-brain barrier permeable agent.
Well, thank you very much. Let's go back a little bit, Rob, to you. And you gave a talk and a discussion this morning on fibrosis and antifibrotic effects, possible antifibrotic effects of the AT2 receptor stimulator compound 21. Now, how strong do you think is this? And is this something that you would consider as a therapeutic goal?
Yes, it's a good question, Thomas. And just to follow on from what Colin was saying, I mean, there are certainly some stroke indications, but I think in terms of fibrosis, there's even just as stronger evidence that possibly something like compound 21 could be an antifibrotic action. The unique thing about the AT2 receptor, the protein, is that it's upregulated in many disease states, and a classic example is in heart failure, where there's a marked upregulation of the AT2 receptor in fibroblasts, for example. So I think certainly in lots of preclinical models, we know that compound 21 has got a marked antifibrotic effect, as good as an ARB, sometimes better. So I think there's every possibility that stimulating directly the AT2 receptor could certainly ameliorate fibrosis.
What do you think about TGF-beta as a common denominator of this antifibrotic effect? We had some results in which TGF-beta was really suppressed after treatment with compound 21. Others have seen similar things. Is this kind of a hallmark, or is this a parameter that we should look at in the future when we estimate the antifibrotic potential?
I think it's certainly a player. TGF-beta will drive collagen synthesis, and so this is one indicator that compound 21 is able to interfere with the synthetic processes. But we've got to remember, when we're talking about the extracellular matrix, we've got mechanisms which will produce collagen and a pro-fibrotic response. We also have enzymes, metalloproteinases, which will degrade the collagen as well. So there's going to be a balance between synthesis and degradation, but certainly from the data that we saw from your group and from others, including ourselves, which is unpublished, that compound 21 can markedly reduce TGF-beta and therefore probably interfere with collagen production.
When you had the choice to choose for the first indication for compound 21, what would be your choice after you have said this, what you have?
Well, in everything we've discussed over the last 2 days, one of the common factors there has been a marked reduction in fibrosis, also a marked anti-inflammatory response, which clearly is happening in the brain, also in the periphery as well. So yes, certainly an antifibrotic therapeutic potential is there. Picking the right clinical condition to go with is another question altogether.
And Colin, what would be your first choice of an indication?
My first choice. Well, my first love at the moment is stroke. But having listened to the last 2 days and knowing the stroke field, I would have to agree with Rob that some form of fibrosis. Now, the area of fibrosis that I know best is the one associated with pulmonary hypertension. Perhaps because I'm involved in that study as well, I have a little bias, but having listened to the last 2 days, having listened to the anti-inflammatory effects, the anti-fibrotic effects, I would tend to lean in that direction. However, in terms of stroke, and I will say something about this, the thing, when in listening to Mark de Gasparo and his advice about what to target an area where there's nothing really available, target an area which is of great need. I think stroke fits that bill, and I know that whatever it was, 164 or thousands of compounds have been tested and have all come to nothing in stroke, but that to me doesn't mean that we don't keep trying in that area. And in terms of compound 21, at least 4, if not 5 groups have tried compound 21. It's been highly effective in stroke. So I think there is a huge amount of potential. I think it has been studied, as Rob said earlier in his talk, in terms of hemorrhagic stroke, but I think that they didn't look at it in terms of the brain, in terms of the hemorrhages. So to me, that's another open avenue. But one of the things, or one of the hallmarks that you have to comply with in terms of stroke and in terms of developing a stroke, something that's going to be therapeutic in stroke, is to use it in multiple models. So I think it's past that benchmark already. It's been proven in those. So I wouldn't give up on that in terms of ultimately being a therapeutic target.
Despite the fact that so many drugs have been tried and that stroke is the graveyard of developing drugs?
The graveyard, I heard that from Bjorn this morning, the graveyard. I still think that what are you going to do for people who have strokes? It's that question. Do you just simply throw your hands up and say, we can't put them in bed and hope that they get better, or give them a Band-Aid? So I think there has to be some research going on it, and I look to the possibility of maybe a combinatorial approach, C21 with other agents, perhaps even a MAS agonist down the road.
It will have to be with other agents, because other agents are mandatory or being used in stroke. So if one would put it into the clinic in this indication, it would be always an on-top treatment of what we have currently.